Thank you for being here. Good morning, everybody. We are going to get started to our second learning collaborative. We did this yesterday, and it worked out really well, so I'm really looking forward to today. Very excited about this. I'm Peter Esselman from the University of Washington in Seattle, and I have the very short-timer job as president-elect right now, so come to the business meeting, and you can see the passing of the baton or the wand or whatever. We are, in this Learning Collaborative, going to introduce things this morning, have a more interactive session this afternoon, really talking about the acute and post-acute care continuum. So really thank you for being here. My thanks to Ed Bernetta and Marlise Gonzalez-Fernandez for being co-chairs of this, and our panelists, Jeff Fine, Mike Lupinacci, Amish Patel, that we're going to hear from in a bit with that. I'm going to launch us off and give you a little bit of a story of how we got here to these learning collaboratives that we're doing with that. That we started years ago thinking about visioning PM&R bulb, really with the goal of developing a unified vision for the specialty of physical medicine and rehabilitation, not just for the academy of PM&R, but really where is the specialty going with that. We've transformed that into advancing PM&R bold, and that mission is really to transform the specialty to align with that new vision. I'll pause a second and let you notice on the right-hand side we have artists giving a visual representation of what we're going to talk about this morning. You may have seen some of her work from yesterday. And I would encourage anyone to come up with a buzzword or a phrase that she captures. And because if you say the right three words, so the right buzzwords, it'll land on the chart there, thank you. So really, we started this, and many of you participated in this back in 2016 and 17. We started with surveys, town halls, focus groups. We did site visits around the country to get input from thousands and thousands of physiatrists, of our members with that. We took the results of that. We convened a summit of 50 leaders in the field to do that, to again develop that vision for the specialty. Brought that to the board. We went through a strategic planning process and came up with the vision. And then we, in the practice areas, like acute and post-acute care, we drilled it down to a think tank of 10 to 15 people, again, leaders in the field, to come up with the vision and the plan for those practice areas. I think of this like we're starting at thousands, we get to 50, we get to 12, now it's time to bring it back to the thousands, and that's what we're doing here. It's time to take this message back to you, all our members working in this area with that, to help us, give us information today, but help us transform the specialty going on into the future. Why do we need to transform the specialty? I think you probably know this, but we have an opportunity. Healthcare is changing. It's changing quickly. We have an opportunity that we're better at team leadership than anybody. We do patient-centered care better than anybody. Holistic medicine, we do it better than anybody with that. These are where it's going with that. We have the opportunity to step in for better patient care, to educate people on what we do, function, quality of life, and change the way we practice with that. We have to take the lead. If we don't do it, someone will do it for us. It gets again, rapid changes, window short. We can help define population health. You hear a lot about population health. I'm not sure anybody really knows what that means with that. I think we have a vital and important role in population health as I envision it with that, and we could prove our value to the system through population health management with that. And if we don't do it, someone else will. Either a regulatory agency will define what we do, or if we're not careful, some other medical specialty will find that niche and circle around us, and then all of a sudden they're in that niche and we're not in that niche. And we're looking like, oh, we should be there, but they own it already, or so we gotta get there first with that. We are a very diverse specialty with that, and we really need And we as the board, we talk about this a lot. In that diversity, we need all physiatrists to think as a physiatrist, even though you're a specialist in any of our specialty areas with that. Because we got to pull together in the same direction with that. We got to learn from each other, share our experiences and our diverse perspectives. And that's leading off into this morning's session and into this afternoon session. We want input from you to help us on this journey. So let's talk about the practice areas here. First of all, the vision of the specialty. This is what we came up with that. It's always worthwhile. If you haven't seen this, read through this, that we are the essential medical experts in value-based evaluation, diagnosis, and management of neuromusculoskeletal and disabling conditions. We are indispensable leaders in directing rehabilitation and recovery and preventing injury and disease. And we are vital in optimizing outcomes and function early and throughout the continuum of care. What I remember from this, every time I see it, is those three words. We're essential, we're indispensable, and we are vital. Think of that. In the healthcare system, we are those three words for our patients. So, in the practice areas that we're doing, the learning collaboratives are, one is musculoskeletal medicine that we did yesterday with that. And our vision there is to align musculoskeletal medicine, physiatrists doing that work with primary care as a frontline partner. And in acute and post-acute care, what we're talking about today, that we're the recognized leader across the acute and post-acute care continuum with expertise in managing utilization of resources and achieving maximal patient outcome. That's our goal from this. Other practice areas that we're working on. We have had think tanks on cancer rehab. We had that this summer. And pediatric rehab medicine. We had a think tank this summer. So those will be rolling out to vision for those specialty areas, to learning collaboratives there. And we're formulating where we're going with pain medicine, but that's next on our list over the next year to do a pain medicine focus as a practice area. So, morning session now, we're going to have the panelists, we're going to have a little bit of discussion with that, but I think the interesting part comes this afternoon with that, where make sure you come to that, bring your friends, bring your colleagues, more interactive. I'll point out now, that's over at the Hyatt with that. We're having the afternoon session at the Hyatt because they gave us a little more flexibility about room size and that. We can flex the room size a little bit if we. I'd love it if we get 100 people this afternoon. We have room for that. If it's 30 or 40 people, we have room for that with that. So bring your friends with that. I've heard about learning collaboratives now for about a year, and my first thing was, what's a learning collaborative? Like, really? What's the vision for this? And I'm starting to get it. It's really to facilitate dialogue and exchange and hear from you. That we created this vision from all that work. We heard from you to create this vision. We got to hear from you back to make sure we're on the right track. And how do we implement the vision moving forward with that? That we got to work together to figure out the vision in all of your individual practice settings. So, again, just to reiterate, and I've said this like 3 times, we started thousands, went to 50s, went to 12, we're going back to thousands. We need to get the message out now to all our members working in these practice areas. It's been a 2 to 3 year long process, and it's really, I don't know, for members of the board, myself, it's really exciting to get to this point because we've been working on this so long. The staff have been amazing. The academy staff have been amazing pushing this forward and setting the mechanics of it and figuring out how to do this. So what have we done? The check marks. We created the strategic plan. We have a PM&R Bold Steering Committee that is chaired by the President-elect of the Academy. Our co-chairs for each practice area are on that steering committee with that to lead the overall Bold process. We're aligning our volunteer structure and resources to PM&R Bold. It really has become what we do with that. We're creating a specialty brand expansion, strategic coordinating committee to get us out there to help expand our reach and our value, and engaging members through this. So with that, I'm going to turn it over to Dr. Burnetta, Dr. Gonzalez-Fernandez for the rest of the session. Thank you.
Just to introduce myself, my name is Dr. Edward Burnetta. I'm an independent practitioner. My practice is 100% ensconced in the post-acute setting. I am the medical director of a 20-bed IRF at Nazareth Hospital in Northeast Philadelphia. I have a consult pain management PM&R practice in which we go to 36 nursing homes. I work with 8 nurse practitioners to achieve that coverage. I have this most recent year, I've contracted with 2 iSNPs, which are insurance companies for the long-term care patients. That's something I would love to talk about more at the Learning Collaborative. And I have a letter of intent in Washington with a Physician Technical Advisory Committee with a proposal for an alternative payment model in the post-acute setting, which would feature Physiatry as the leader of that post-acute model. In a brief synopsis, it's basically taking the leadership role that we have in the IRF setting and running the interdisciplinary team and transferring that to the SNF setting as well as the home health care setting. So I'd like to introduce Marta. She's going to go through the slides prior to the panelists.
Well, again, welcome everyone. We're happy that you're all here today. I'm Marlise Gonzalez-Fernandez. I'm Vice Chair for Clinical Operations at Johns Hopkins University School of Medicine. Been doing a little bit of in every practice setting since I came to Hopkins, primarily being also a physician scientist, so more to come. So we're talking about leading. And I think that should be kind of at the forefront of what we are thinking. How can we lead in the acute and post-acute care arena? So again, this is an envisioned future. Like, where do we see our specialty going? And the envisioned future is meant to paint a picture. And again, that's literal, because we have a friend over there. But it's also looking at how we see us practicing in this acute and post-acute care setting. It's meaning to align us in those areas. So again, the future is that we are recognized leaders across the acute and post-acute care continuum, and we have expertise managing utilization of resources. So I would argue that there's no one better than a physiatrist to understand what a patient would need from being admitted in the acute hospital to getting back home and everything in between. So how do we establish ourselves in that arena is going to be really important. And again, you see some of the envisioned future statements that we have, which include, again, directing rehabilitation, managing post-discharge care from the time the patient is early in the acute care through the post-acute care continuum. So we really need everyone's input to figure out what's the best way to establish ourselves as leaders in this area. And again, the physiatric management needs to be timely and needs to be to help those transitions of care. So how do we help care all together in not only getting the services that the patients need, but getting them in an efficient way that really serves everyone? So what would this look like, right? That's always the question. We have vision, but we need to make vision a reality. So we are looking to develop those document those models that actually will foster these goals. So we need to ensure that appropriate physiatric care is there across the continuum of care. So we can, if we have to be present, we have to be at the table. And there's 3 models that we're talking about. So establishing physiatric leaders in different settings, including but not limited to the IRFs that we've been for very long time, but also in skilled nursing facilities, LTACs, and I would argue that we need to start in the acute care hospital if we're going to establish ourselves between other colleagues who are not physiatrists. And model 2 is integrating physiatrists in the inpatient acute care setting, which I was just mentioning, to provide early functional evaluation and recommendations. And model 3 is establishing physiatrists as critical leaders in managing patient transitions across that continuum of care. So again, we need to start, in my opinion, in the acute hospital and move patients through. So the strategic plan, again, was developed with input from leaders in the field, through think tanks. So there's been a lot of brain time put into this work. And it was designed, again, to address the gaps between the current reality and the envisioned future. Like, how do we evolve as the healthcare system evolves in a way that makes our specialty much more effective, to include education, training, leadership, reimbursement, and advocacy, among other things. And again, this was approved by the Board of Governors, and the implementation is being led by the steering committee with practice area co-chairs, which in this case is Ed and I. So what are our prioritized objectives? Again, PM&R needs to be a critical specialty in the acute, post-acute care arena. And how do we make that happen is where we're looking for input, and we have panelists here who have done a lot of this work, who we're gonna hear from, and we wanna hear from you all as well. So again, there are many areas of the academy that tie in with what we're doing in the acute and post-acute care setting, and this includes the registry, the quality groups, the practice policy reimbursement committees, and the brand expansion committee. So there's a lot of tentacles, if we might call them that help us bring together what we're trying to do in this particular care area. Again, we want to highlight attractive opportunities for physiatrists. We have people that have been practicing for a long time in certain settings. We have new trainees and new practitioners, and we want to make sure that we develop resources for people to see opportunity within our field. So there's a lot that can be done, and perhaps some of those opportunities are not in areas that have been traditionally considered important for physiatrists. Another objective is to address the educational need of those in training, physiatrists. Again, greater exposure across the care continuum. And again, we know there's challenges even from the funding standpoint. We know that medical education funding has been tied to hospitals. And how do we train trainees in other healthcare environments will be really important. And we need to get creative as to where that GME funding is coming from. And we want to expand physiatrists' reach, impact, and leadership opportunities through work with advanced practice providers. We know that we need a very large workforce to accomplish these goals, and what is the right amount of use of advanced practice providers and what role they'll play will be important as well, and will need to be discussed so we have a unified vision of how these professionals can support and expand the work we do. So what's going to happen with the sessions today? Well, now we're going to be hearing from our three panelists that are here, and then we'll see what they've done and how they've worked through the acute and post-acute care environments. And then this afternoon, 2 to 5, please remember, it's not here, it's at the Hyatt. We don't want to be all alone. 5 people at the Hyatt, that would not be a learning environment. It would just be cross-pollination that we've been doing already. So please join us there. Everyone is invited. It's a group discussion. We really want to hear what everyone thinks. And then Phys Forum is going to be a great resource so we can continue these conversations. Without further ado, we'll move to our panel discussions. So, our panelists are Jeffrey Fine from NYU Langone Hospital in Brooklyn, Michael Lupinacci from US Physiatry LLC, and a former Academy president, and Amish Patel Dio, who is from Integrated Rehabilitation Consultants, it's also an LLC. And then we'll have some kind of basic questions, some key factors, key questions that we want our panelists to help us answer. And they'll try to do that in a short period of time because we really want to hear a lot more from you and see what you think about these models.
Okay, so hi, I'm Jeff Fine from NYU. I've been practicing for 20 years, my entire practice in level 1 trauma centers, hospital-based rehab, and running rehab departments and as medical director of rehab units in those settings, in Colorado with Dennis Matthews, in New York at Mount Sinai with Dr. Ragnarsson, and most recently in NYU with Steve Flanagan. My experience in running rehab units in trauma centers is primarily based around managing patients with traumatic injury. So traumatic brain injury, spinal cord injury, stroke, orthopedic polytrauma, amputation, and it's in that context that I've sort of managed departments and developed what I think are excellent outcomes for patients based on investing in the department in ways that help the team to work more efficiently. I do think it's important to recognize that as physiatrists, one of the main attributes of what we provide as a clinician, as a leader, is guiding the team, is understanding the strengths of our team, understanding the needs of our patients, and guiding the team to accomplish the goals that the patients and we have established for them in CMG-based timeframes. Now, teams need to be efficient to do that. So in my departments, we've started by developing the team by doing team steps training and Sigma 6 lean training. Team steps is really a team building, a team coordination, a team communication strategy and tool. Lean is really a way to identify waste in the system and how is it that you deliver value to your patients and to the hospital system as a whole using evidence-based tools. So in order to effectively run my department and determine where I can invest the resources that I have to develop programs, we did that training in our department, and everybody's trained in these tools, and it helps us to be more efficient, to align resources and redeploy resources in areas that maybe represent some overutilization or waste. In that context, in trauma centers, my department has been involved from the ICU and the ED to the inpatient rehab unit to discharge planning to outpatient management. So we cover the full spectrum of services that patients may need from a rehab setting. And the team is aligned to access those resources in efficient ways to get patients into the right setting at the right time. Now, sometimes that means the patient goes to a nursing home-based rehab setting, and we participate as far upstream as we can to help make that determination as soon as possible. We use information from our data manager. We use UDSMR as our inpatient rehab data manager that helps us to set length of stay goals, functional gain goals. We set our targets at the 90th percentile of the country to try to do the best we can. We target the mean as close as we can in terms of discharge planning. And I think that I've been doing this for 20 years. Since I started as a resident and then as an attending, I've been constantly hearing about change in rehab medicine. So I don't think that that's going to change. I think that's the nature of the business that we do. It's a little bit of medical Darwinism. It's survival of the fittest, and that means the ability to compete, the ability to succeed, and replicate the model. And I do think that for our specialty, we are in an era of another change. And this focus on subacute, I think, is an appropriate focus for our specialty, because the same tools that we use to succeed on an inpatient rehab unit are the same tools that we can use to succeed in a subacute setting. The patients are similar. The diagnoses are the same. The goals are the same, to get patients back into their lives with quality of life, with independence, to train their families so that they're adequately prepared to serve in a caregiver role if that's necessary, and to help patients establish goals that are not just about toileting and walking and dressing, but about the things that are the fundamentals of their lives, the things that define them. And I think that as a specialty, we do that better than any other specialty. So our positioning in subacute settings to provide the goals for rehab medicine and rehabilitation teams, I think, is critical for us. Now, my primary experience is hospital-based. I don't have a lot of experience with subacutes, although we're in the context right now of generating contracting with NYU for preferred providers of subacute services in our community that will essentially require those providers to provide additional quality metrics that surround rehab and rehab outcomes that are beyond what they're required to report for state regulatory reasons. And if these providers want to elect to have RUSC physicians participating in their facilities, then they have to agree to participate in our sort of data capture for quality metrics. And we have a number of facilities that are interested in that regard. And we can talk more about this in question session or in the afternoon. The two areas of focus for me for today are to talk about our development of an early mobilization program in an ICU. That was an evidence-based program that, in terms of the design, what was the impetus? The hospital had tried to do it before I started in Brooklyn, and it did not work. It was not a success. And so one of my first charters, starting as a new faculty member, was to develop an early mobilization program in the surgical and the medical ICU. So the hospital came to me with the objective, so it wasn't that there was an impetus for me to have to start it. The hospital had requested for me to do it. But we took the time to review the literature, to look at clinical practice guidelines and consensus statements from the literature. And a lot of that work was actually done by me, assigning reading assignments to the committee as we developed the program. So before we started, we read probably 40, 50 articles, including consensus statements, to develop a treatment plan that was evidence-based and we knew was going to be safe. The second part then was building the culture in the ICU, that a physiatrist was going to be the one directing the treatment plan and implementing processes that allowed their team to be efficient with the new process, that didn't add additional time to their day. And it takes time. It takes a commitment of multiple different teams to build a program like that, multiple different disciplines, from nursing to transportation to respiratory to our therapies to social work. And everybody was at the table in our planning meetings in order to design a program that we knew would work in that setting. The second program that we developed was looking at the fact that as inpatient admissions change and joint replacements are no longer considered to be sort of appropriate inpatient rehab candidates, we aligned with the bundle plan, and I ran the committee for joint replacement with orthopedics to design a rehab program that took advantage of all our skills managing those joint replacement patients and pushing the management upstream into a preoperative joint camp, where all of our physiatric assessments, assessing patients for risk of bleeding from surgery to DVT prophylaxis to availability of a caregiver to assist, a champion for the patient in the post-op period. We moved all that decision-making upstream, so all the assessments happened before the patient arrived for their surgery, including teaching them a home exercise program on their phone. We partnered with a company that we designed a home exercise program that patients began before they even had their surgery. And in the process of designing it, we realized if we're putting all this effort in just to meet a CMS standard, why not go for a Joint Commission advanced certification for hip and knee? And in less than 10 months, from a program that started from scratch, from zero, we not only succeeded in the bundle, but we designed a program that was certified by Joint Commission in less than a year for both hip and knee replacement. So the point is that using our skills as a team coordinator and knowing where your resources are and being efficient with lean principles, you can design a program that really doesn't, that takes advantage of the resources that you may have already with not a large investment to build programs of quality that the hospital appreciates, that are revenue generating, and that give recognition to the hospital and the department as a whole. So the skills of a physiatrist running an inpatient rehab unit can be redeployed in a lot of different settings. In a continuum in a hospital, so you're providing a vertical integration of services from ICU and ED to inpatient rehab to outpatient, but also those same skills can apply in a subacute setting as well.
Good morning, everyone. Was that an epic party last night or not? I think that was an epic president's reception, so we all enjoyed it. Was trying to think how I can tell you a little bit about what our concept of care is. I'm the Chief Medical Officer of U.S. Physiatry. And what I've realized, we've chosen to do something that is not expedient, but that is extremely difficult. So we're basically a national group private practice, and we're led by physiatrists. So the initial concept was, from the leadership in the start, imagine a world where you as the physician would walk in, you're respected by all those around you, you had a protected practice that was going to make sure you weathered the business of medicine, and you were the captain of your ship. Doesn't exist very much anymore, or certainly it's threatened in any event. So the mission of U.S. Physiatry really is to provide best-in-class care across the post-acute continuum. So we have providers that are in IRFs, acute care hospitals as well, LTACs, and SNFs, and across pretty much all aspects of the continuum. So the goal was really to preserve and protect independent private practice and give the private sector the ability to innovate, which is being stifled in that sector, as we all know. So the business model was, excuse me, we wanted to provide a high level of support for issues with practitioners that involved issues of high importance or issues of quality. In the same time, we wanted to give them, as our doctors, independence in what they did to be their own bosses. But we wanted to make sure that the practice model, and we are a group practice, we function as a group practice, was a model that would give the practitioner a high ability to adapt, a low ability to deal with bureaucracy, in other words, have none within the practice, and a high degree of autonomy. So it's kind of I've envisioned a perfect world, right? That'd be great. So right now we have 89 providers. We serve 200 facilities, and we're in 80 communities, and we're growing quarter by quarter. So one of the main issues is that we had to decide what did we want the business model to accomplish. We thought we needed to have an integrated central core, which is our practice. We needed to be able to position our practice to not only provide best-in-class care, but to leverage our group power, both in cost reduction and contract negotiation, and to prepare our practice to deal with the volume to value transition, which is inevitably happening. So those are the two main streams of the business model. The other thing that we needed to make sure of was that we had this protective sphere around the physicians of the business practice of medicine, because it's volatile, as we know, in this healthcare dysregulation. And so not only do we provide a sphere of benefits, the usual health, medical, dental, vision, long-term care, but we wanted to help them reduce their IT costs, which we all know are the black hole. We wanted to protect them from regulatory changes. We wanted to provide macro and MIP services to help them meet the quality measures, to help them do better care for their patients as well as get paid for it justifiably. So the sphere around them has to be solid. And the way we make that solid is that because we have economy of scale, we can afford really competent people to administer and manage the services, and to have first-class customer service. Our customers are our doctors. So that's basically the core. There are other aspects of it. So let me just describe briefly. So we're in a lot of different communities, right? We're not in a highly integrated, localized practice in a city. We're all over the country. So we're in Seattle, we're in Miami, we're in Kansas City, we're in Columbus, we're in Harrisburg, where I am. And all of those markets have different degrees of sophistication and maturity. So some markets, like my market, we're in acute care, we're in the SNFs, we're in the LTACs, we're in the IRFs, we're in all the quadrants. But others may have only 2 of those, but usually all of our locations are in at least 2 of the post-acute sectors. And so in order to help providers channel pathways of care, as Dr. Fine was describing, we had to develop a very, very tight education and clinical mentoring program. So for our new physicians, we make sure that they have easy access if they have a clinical question, because they're still maturing, many of at least the younger docs. More importantly, for those taking on administrative and leadership roles, and we promote that within the company, consistent with BOLD, we mentor them for leadership skills, for all those slippery slopes of physician administrative interactions. We're there for them before they happen in an educational format. We have online education as well as on-site education, but we're also there virtually. So if they're sitting outside an administrator's office and there's a conflict and they want to call or text us while they're sitting there, they can. This is the type of help that our doctors need because the environment, as you know, is so unstable. And if you look at it in a national perspective, every pocket is unstable, equally unstable. Mergers, acquisitions, every community. So that's basically the principle of where we're coming from as a group practice. We're one entity. We are attempting to be a solid entity that's very mobile and fluid and adaptable. The last thing I want to mention is that we have a development team that really involves all the leadership as well as some specific individuals that help with our community and administrative development, not only helping add new communities to our services, but also helping to, let's see how I put this as, to develop, maintain, and repair hospital and administrative and physician relationships that our physicians encounter every day. So they're full-time for that. So that's a capsule of U.S. Physiatry, and I'm probably over my time, or just within it.
Thank you very much.
Hi, thanks everybody. First of all, obviously thank you for showing up on a Saturday. I think you'll notice a lot of similarities to U.S. Physiatry and Mike's group and our group as well. I'll delve into some of the details, try to stick to the bullet points, but the name of our group is Integrated Rehab Consultants. Started in 2010. We've grown to about 350 post-acute facilities, skilled nursing facilities. I probably have about a half dozen to 10 IRFs. As Dr. Gann said yesterday, we truly believe IRFs aren't going anywhere. There's going to be a continued need for IRFs. But I also believe in a statement he made after that is, we'll get into a little bit more detail on what our company does, but to encompass what we do, make that SNF your own IRF. And there's ways in which you can do that, and there's ways you can't do that. I think we'll get into more detail in the actual workshop. But the idea of our group and most groups, what you all should look into, whether you sign up with Mike's group, my group, you work with a smaller group like Ed, I think you really need to look at, do you have the benefits of a larger group? And as involved as Ed is, even though he's a smaller group, he's very involved. You need that level of involvement now, whereas before it was just, hey, I'm going to go contract with a skilled nursing facility. I'll come in and out when I want to. We'll have some doctors who are busy, some doctors who will show up, and if they don't have any time, they won't show up for a week or two. I think when you get into what did work for the group and what didn't work for the group, initially we've evolved quite a bit over the course of going into our 9th year. At first, it was a lot of find the doctor, fill them into a facility, have some sort of communication with the hospital. The process is a lot more formalized now in terms of how you engage hospital systems, especially when you're an independent group such as ourselves and Mike's group versus Dr. Fine's group. When you're at the hospital and you're pushing things from the top down, it works a little bit differently in terms of what you need in communication and resources. I think any group that you work with, you need to ask them, you're keeping X percentage of what we make. What are you doing with that? What's the group investing in? What are the benefits of joining a certain group versus another group? I think if you look at the group today versus when we started it, Dr. Natz is our Chief Medical Officer, past president of the AAPM&R. In terms of initiatives we've engaged in, you're looking at some key buzzwords that you guys will hear a lot: population health, value-based medicine. What do those things mean? It really is different. I think we're very good at physiatrists at providing qualitative care in which we can all look at each other and our facilities will all look at us and tell us, yes, the facility would not run well with Dr. Bumetta. If Dr. Natz wasn't in our facility, we would definitely miss out. But to take those qualitative measures and turn them into quantitative measures, it's very important. I think as you look at CMS, different bundles, different risk share programs, you need to be able to show value in a quantitative sense. So what does that mean? Your things that you're always hearing about: return to hospital rates. You're going to hear about length of stay, 30-day post discharge readmission rates. Those are the type of measures our group is following. I think Mike hit on a little bit about, your group, whether they're large or small, they should be able to help you with MIPS, MACRA, those type of issues. It's really difficult now to be a solo practitioner and go out and tackle everything you could in the past. Before, it was much easier. If you wanted to go pick up 2 post-acute facilities, do a great job. There's nothing wrong with that. I still encourage solo practitioners. It's just more difficult to do it the right way. We found when we were trying to engage hospitals, and we had a few case studies, and I encourage everybody out there, again, this is something we'll get more into the workshop, is get outcomes. You may not start with fantastic outcomes. You may start with something that's not a statistically significant study, but even if it's in your one building, really go out there and get those outcomes, whether it's over 20 patients that you worked with over a month, or whether we ended up doing a larger study with a population health doc. I think we had tens of thousands of visits in our 4 major markets. We showed a return to hospital rate that was lower than the national average, a length of stay that was lower than the national average, and they turned out to be statistically significant, which was important. But whether it's a study with that much a broad study like that with a lot of depth, or, like I said, more of a case study, you need to get those. And when you're engaging hospital systems today versus a few years ago, what do we see today? Now, when I first started in 2010, Dr. Tariq started with us in 2011, 2012, you used to be able to take your studies to the hospitals that were forming these post-acute networks, and they would look at your study you brought, and then they would look at a competitor that may have a physiatrist, then maybe 2 other competitors that didn't have a physiatrist, and they really kind of took your word for it. Like, this is what we're doing, here's our outcomes. Today, honestly, if you show up and you just have some numbers which are not really vested in what truly happened in the building, the hospitals know exactly what happened. So to get a proper study done, to get real numbers, it really changes the way you're able to approach it. So I think as physiatrists, we tend to be, again, getting back to what I think the main key point I want to push across is, whether it's a group like ours or whether it's like Ed's in terms of size, really getting quantitative studies done. I think we can all agree, and our facilities will love us as what we do for physiatrists. A few things coming down the pipeline. I know I'm running a little bit out of time, but PDPM is something that you guys will hear more and more about. PDPM is something that will come in October of 2019. What is PDPM? The exact parameters aren't set yet, but it's basically going to utilize a certain amount of therapy gets paid at an optimal level, meaning if you can discharge your patient, right now the setting is around 20 days, you will get full reimbursement to that 20 days in a post-acute center. After that, you'll start to get a decreased reimbursement based on a specific diagnosis. Now, what does all that mean? It sounds like, a mess of words, but the reality is the need for a physiatrist in these systems is much greater than it was in the past. Before, when we started 2010, 2011, if I came in and I talked about I wanted to reduce your length of stay and I want to reduce your return to hospital, they get paid per day the same amount up to 100 days. So boom, point A that a physiatrist says, they're like, yeah, that's great, but we're not that interested. 2, return to hospital. 2010, you weren't dinged for readmissions back to the hospital. When you went to the hospital, if you got readmitted, a lot of the primary doctors were not very involved in these facilities. So what happened is, if someone had a UTI and they had another UTI, great. Send them back to the hospital. Maybe they'll get a night in the ICU. That ended up hitting the bottom line. Now it hits the bottom line in a different way. Everyone's fine for readmissions. And then again, with PDPM, when you're looking at not just getting somebody out in 20 days, but again, remember, you can't just have an actuary sitting there and be like, okay, get this diagnosis out in 20 days, get this diagnosis out in 12 days. If that person gets readmitted after that, then the whole system loses. So in terms of value and utilization of a physiatrist, I think we're more needed than ever. I really believe in what Dr. Gann said in terms of make these centers your own. In terms of what you should look for groups that are going to invest in you, whether it's somebody like a Mike or a Dr. Natz, or who's doing your MIPS, who's doing all these measures. You can't be an independent practitioner out there if you're not going to pay attention to all the details anymore. So I've done a pretty good job sticking to my time. But again, we encourage you to come to the workshop. I know Dr. Natz and Dr. Tariq have a post-acute talk in the afternoon as well, and we look forward to more dialogue as we move forward.
Thank you to our panelists, and the floor is yours. I'll leave you with Dr. Burnett.
Actually, if I could ask a quick question, Jeff, you were talking about going into the ICU early and having physiatry involved early on. Have you found with that particular model, does that enable you to become more of a decision maker early in the ICU admission in terms of what would be the appropriate setting?
Yeah, so our patients are assessed on day 0 or day 1 at the ICU. Every single patient is screened as to whether or not we've developed a safety protocol as to who's safe to mobilize. And if a patient is red, we're not mobilizing on that day. If they're yellow, we're mobilizing with caution. And this is all input that's derived from literature. So we've developed a safety algorithm from several articles that were based on consensus statements from a number of groups, but particularly out of Hopkins. And then that conversation begins. Patients are mobilized on vents. About a third of our patients are mobilized every day on vents. And from that initial assessment, we're determining their activity tolerance. So we're starting discharge planning in the ICU long before they get out of the ICU.
Has that had an effect on length of stay, or have you been able to look at that yet?
Yeah, we have. So it reduced the length of stay in the surgical and the medical ICU by about 1.3 days. And that translated into a shorter hospital stay, as well as greater discharges to community.
Yeah, thanks. Dr. Steve Netz, the Chief Medical Officer for Integrated Rehab Consultants. I was looking at your first factor for the impetus of your model. I started in subacute rehab back in about 2011 or 2010, something like that, because I was a medical director of an inpatient rehab facility, and I was wondering where all my patients were going. So I found out that they were going to skilled nursing facilities, and I just followed them there. And what we started to do was apply a model of physiatric rehabilitation to the skilled nursing facility to be able to take care of our patients that had left the IRF and were now being cared for in a skilled nursing facility. And that's basically the foundation of our model, of why we're there. Some of you know, I presented last year or 2 years ago and have a bumper sticker that says, every physiatric patient deserves, every rehab patient deserves a physiatrist, right? That's my bumper sticker. And I think it should actually become the slogan of, I'll actually give it to the academy for free, no license involved. So every rehab patient deserves a physiatrist, because you have levels of care where there is no physiatric management of patients that are undergoing rehab. There are more patients to get their inpatient rehab in a skilled nursing facility in America today than in an IRF, right? So we need to be out there with our patients. That's the first thing, is patient care. So the other thing I would like to ask the panelists, though, in IRF, we have a mandate, right? You have to have, they call it a rehabilitation doctor, but everybody knows, the preferences for a physiatrist. Do you think that we need a mandate to have a physiatrist or a rehabilitation physician in charge of the rehabilitation in other levels of care?
Are you sure you want to ask us that question? It's like the cat watching the hen house. Of course we do. All of our patients are going there. Steve, I ditto everything that you've said. I think it's inevitable that SNFs are going to be forced to have some increased structure, increased efficiency, and we need to be there. And I think that's what IRC is doing and what we're doing. The more we're there, the better the patients do. And we can help them with all their metrics if they just let us go and work with those facilities. So I think it's a no-brainer. And really, with managed Medicare, all of our patients are going there. I mean, you can see the exact same diagnosis, the exact same complexity, the exact same, sex, the exact same age, and they're in two different facilities because of their carrier, which I think is a big problem.
Steve's obviously a company man, so I agree with everything Steve said. I think it's difficult just because in the talk yesterday we got into the sheer number of SNFs spread across all 50 states and more rural areas like the Dakotas and Montana. Just like it's hard to cover IRFs, there's dozens and dozens and dozens of SNFs in the most rural areas ever. So I think having a mandate would be great. It would probably have to be loosely worded again, like some sort of rehab-trained physician. The truth of the matter is, in most of my facilities, I still see probably 30-plus patients 4 to 5 times a week. I would say the vast majority of certs that are signed by the primary doctors have no idea why they're signing a cert or what contact guard means. And at the same time, CMS is losing a lot of money out the back door based on doctors recertifying patients for rehab and having no idea what's going on with rehab. So it just goes to show that obviously, at some point, there needs to be some sort of language written in that, at least if you're willing to sign a Medicare cert or recert for a patient's rehab, you should be educated on what that patient's doing in rehab. So whether that physician wants to educate themselves or they want to consult with a physiatrist or, a rehab-trained doctor, as they like to say, I think things are going in that direction. And just to put a plug in, like Mike said, we definitely think that the AAPM&R should take that stance, so.
Okay.
Hi, Perry Stein, Medical Director, Mercy Medical Center Inpatient Rehab Facility. So we are, many of us, medical directors in inpatient rehab facilities. Kind of by definition, we have the credentials to do so. Does it make sense for the Academy of PM&R to develop a curriculum or a certification course to be, if not overall medical directors in subacute or nursing facilities, at least for the rehab portion of it, medical director in charge of rehab in the nursing facility, something along those lines, so that rather than just touting ourselves and demonstrating what we can do, but there's an actual coursework and some kind of a title that goes along with it. Thank you.
That's a great question, and we didn't plant you in the audience to ask that question, but I have a pretty good answer. I have a pretty good answer for that. So next year, the Academy is planning, and Peter, I'm assuming I can give them a preview of that, is planning really some formalized leadership training, and I was on the committee that kind of helped launch that. It has 3 parts. 1, there's online leadership training. 2, we have an affiliation. We have an affiliation with the Kellogg Business School to do on-site leadership training at Kellogg, which is one of the top leadership schools in the country, leadership business schools. And the 3rd thing, to answer your question specifically, is within that curriculum, we're developing a curriculum specifically for medical leaders in physiatry to include medical directors. There's going to be a specific sub-course in that. So thanks for asking that question, and this is a preview of what's to come. Please.
Andy Kirstens, Greensboro, Cone Health. Had a question. We all know rehab is a continuum, and it starts in the ICU. Physiatry involvement starts in the ICU and ends basically in the outpatient setting. My question is for these large national medical groups. To my knowledge, they aren't really involved in any outpatient care, and how do they coordinate with community PM&R docs to get follow-up for these patients? Because a lot of times they go home, they have severe spasticity, they would benefit from Botox or other physiatric services. So I'm just wondering if you guys have any plan to kind of coordinate or cooperate with local physiatrists that have outpatient clinics.
I think we've seen this more and more in terms of the one word that you can say is communication. I think discharging patients, whether obviously opioids are hot button topic, but whether it's some sort of follow-up needed. I think when we discharge patients from the hospital or the IRF setting, physiatrists, a large percentage of those are going to a post-acute setting. For us, when we discharge from a post-acute setting to home health, the key word is communication. So having an actual plan written out that the social worker knows, whether that's in a discharge care plan with the social worker, give that to the patient, and then there's some follow-up. I would tell you that 7 years ago, I probably didn't know the names of any of the home healths that we worked with and we discharged to, whereas today, at least in our setting, for me specifically in the Chicago area, I know pretty much every home health that's getting our patients. Now, certain home health may be one that an orthopedic surgeon prefers. Certain hospitals now have their own home health systems. We're pretty agnostic in who we work with. We don't have our own, but definitely we do ask for more follow-up in terms of them getting information back to us and then on our end communicating a proper discharge. So those things are handled better than, like I said, I think of myself as at the very least an average physiatrist, but 7, 8 years ago I didn't really know where they were going. But yeah, the people fall through the cracks if you're doing that.
I was going to say even in a large system like Hopkins, where you have coordination between levels, that is probably our most difficult transition right now. The transition from all these kind of inpatient managed home care and then making sure that patient doesn't fall through and gets to outpatient services is probably one of our hardest. And we're actively looking at it. I don't have an answer for you as to how we're going to make it better, but we recognize that that's a difficult transition that we are not paying a lot of attention to in the past.
I think the IRF to the outpatient clinic is pretty easy, but I think the IRF to the SNF to the outpatient clinic, that's right.
One of the things for the communities that we have providers, our group in all levels of care, our goal is to facilitate not only outcomes management in each setting, but to facilitate the communications, because we all know EMR is just horrible at communicating information. But if I was going to have one word to answer that question, the word would be manpower. We can hardly get enough physiatrists to do all the inpatient needs we need in all of those settings. But I like the point, and I think the point is we really need to, and thinking about it in all of our areas, is to develop networks of outpatient physicians for at that end point of inpatient care that we have an automatic, at least where there's enough manpower, we can do it more automatically. It's a great idea.
I'm Mike Preby. I'm a physiatrist, and I work at the VA, practicing the logo there. So the VA system, I think, is a piece that I want to make sure is somehow incorporated in this bowl, because the PM&R started with the VA, and the VA started with rehab. And rehab is disappearing from the VA, at least physiatric leadership is disappearing. Most chiefs of rehab, at least in my area, are now PTs in the VA system. Because we can't find physiatrists who are willing to go into VAs that don't have a good academic affiliation. Those VAs who have a strong academic affiliation, they're really good, well integrated. But those of us who work without an academic partner, or an academic partner who does not have a PM&R department, are really out there on our own. And the VA needs that care transition coordination. It's a great place for both acute rehab and subacute rehab. Talk about musculoskeletal and pain need. With the whole opiate safety initiative that the VA is going on, primary care providers, just as mindlessly as they pushed people onto opiates, are taking them off and then saying, well, what are you going to do? Well, I'm sending you to PM&R, and totally overwhelmed the system. And so somehow if we could incorporate a vision that really captures the VA system is an ideal place for physiatrists to work and grow and develop. And it's kind of like the stepsister that got forgotten. So I want to just push that horn and toot. Thank you.
Thank you.
Thank you. We will toot with you. Yes, please.
Hello, thank you all for this session. I have, I guess, one kind of story from my practice and two quick questions. My name is Timmy Twamkum. I'm a practicing hospital-based physiatrist. One thing I found to be very helpful when I started in my practice was I worked with the hospital to get a reflex consult for all the stroke patients. And so I had them auto-consult PM&R. I did that in my first year out practicing. I worked with the hospitalist group and the stroke coordinator. And it's worked out great. I found the social workers loved it, the patients loved it, because what would happen is I would see the consults, I'd see them in the acute care setting. Then by the time they come to rehab, the patients really love it because it helps build rapport, because they've already met their doctor. When they're coming to rehab, they're kind of a little antsy before. So just having seen your face and having that as a bridge also helps. It also helps prevent your patients likely from going to skilled by you having seen them. The social workers are happy because you've seen them and accepted and you've taken work off their plate. So it works out well for everybody. It also helped decrease their length of stay. So the hospitals love that. So it's something that's worked out well in kind of all regards. I do have a quick question for the academy. Has there been ever thought or push to work on getting like a modifier for team conference days, since we're required to do it 1 and 7? So, somebody knows the answer? Huh? But there's still going to be a requirement in E&M. You know, I mean, if you try and charge a level 3, it doesn't really always equate. It doesn't really always equate because you'd still have to have 2 other little bullet points. That gets you 2 points of the 4 points you have to have by discussion with another team member. But the other 2 points you'd have to get would either be from a lab or imaging, so that you'd have to find another way to get the 2 other little check boxes for you to below level 3. Has there been ever thought of adding like a modifier to add a smaller amount to do those for team conferences? That would also eventually be helpful in the skilled setting.
I'm not representing the academy at this moment, but I can tell you, none of us in this room disagree with you, but the reimbursement committee is fighting to keep what we have and not lose what we have. That's where they're putting their efforts and energy. And to add anything in the environment of CMS right now, to add a code, to add a charge, is not really going to be well received by CMS. So we're fighting to keep what we have, which is an unfortunate position to be in.
But I really, to document time for like a
what-
level 3 would
do you
be
have
35 minutes.
Do you have another question?
Yeah, quick question. This was a quick question. Quick question was, you mentioned doing, setting up an evidence-based program for the ICU consults. If there's a format which you could share the articles you used to kind of establish your guidelines, that I appreciate.
Sure. So come to the afternoon session. I'll show you my references. And
I don't think I can make it, but I can ask you afterwards. And then I have one last comment that I'll pass the floor. If we try to take the position that for subacutes that we need a physiatrist, I think we would be way too early to say, make this some sort of requirement and then trying to define what rehab is. Because what'll happen is, if we're talking about in the rehab setting and saying it needs to be a rehab-trained doctor and really wanting it to really be a physiatrist, if we make that stance when we're in a setting where we don't have the full capacity right now, I mean, maybe we'll get there to where we really can cover all the skills, then we create a problem, and then we're wanting to make it vague there. That's a problem for, if we try to make it vague there, but then we're trying to narrow it in the inpatient arena, that's a problem. I mean, it goes back to what he was saying about, not wanting having a non-cardiovascular surgeon to run a cardiac center or cardiologist. I don't think that that's a good idea by the academy, just because we'd be fighting ourselves in one other arena for an arena we're not fully ready for yet.
Good point.
Point taken.
Hi, I'm Denise Ozell, CMO for Northeast Rehab Network. As most physiatrists, I'm a huge proponent of having physiatry involved in all levels of acute and post-acute care and all rehab. But there are limited numbers of us, as everybody has mentioned, and we can't be everywhere. So I was wondering if you could talk a little bit about how, if you're using advanced practice providers, nurse practitioners, and physician assistants, where are you using them, and how are you using them, and how are you training them to, for physiatric kind of work?
It's right up
I would love to talk about that this afternoon. How about we have, as part of our conversation, we can interact regarding the nurse practitioners.
Okay.
Fair enough?
I'm Gary Goldberg at Hunter Holmes McGuire VA Medical Center. I've been doing brain injury rehabilitation for 35 plus years and electrodiagnosis. So the issue, there's two issues I see. One that keeps coming up. One is the manpower issue, and the second is the communication about value added. What is it that we add to what everyone else is doing that they are not doing? And I would argue that we are the physicians involved in person-centered healthcare. We are putting things together. We are putting the body and what's happened to the body together with the mind and the spirit and what's going on with the spirit. And that may sound a little, hunky. I mean, like not very sexy at all, but what I would encourage folks to do is go down to poster set 375 and talk to Margot and Emma and Gabe, who are medical students at Oregon Health and Science Medical School, about how they increased the interest among medical students, fellow medical students, in PM&R as a specialty by 12-fold in terms of the interest group in there. And I don't even think they have a PM&R department there. And if you talk to them about what it is that gets them excited about this specialty, it's that we bridge the gap We talk about the person, not the patient. We talk about the person and about putting that person back into their life.
Yeah, I think there's a real important point to make about the post-acute setting, and that is, in healthcare, that has the highest degree of variability of any other cost center. And to me, that's an area, I think, in business jargon, that's an area that is ready for being, it gives you plenty of opportunity to try to change that variability and have it more quantifiable and have savings involved. So I think that's where physiatry can play a really big role.
Hi, my name is Dr. Aslan Tariq. I'm the VP of Medical Affairs at IRC. I have a couple of comments, actually, not questions. One was about the leadership. I'm really, I appreciate the fact that AAPM&R is working on that. But one organization called AMDA, American Medical Directors Association, they've actually been forefront in the post-acute setting for years now, and we're getting more involved with that. We actually know the president, the leadership, and we're actually working with them to kind of set up something for rehab doctors as well. So in a specialized, some kind of certificate program for physiatrists. So hopefully we can maybe kind of combine the powers because they have the resources for sure. So it'd be great to have that.
That's an excellent point. There's other people involved in this setting, and AMDA is one of them. I got my certification last year, so I'm a SCMD with AMDA. And I know Michael and you guys get involved with them quite frequently as well. So that would be another great topic in the afternoon to discuss that in terms of how do we interact with those. They're basically primarily the medical directors in these units many times. And I think you have a very interesting co-directorship model that I know you've discussed. So
Yeah, they're pushing a co-managed model, which is
yeah.
Right.
So thank
Second
you.
comment, actually, someone asked a question about outpatients. So same thing that Dr. Patel mentioned, that it's a communication issue. So unfortunately, a lot of patients that I have, they have a stroke and they have spasticity and they need Botox, and the facility is not going to pay for that. Insurance doesn't pay for that. There's all these regulations about that. So what I do is I communicate with local providers, physiatrists, for outpatient follow-up. So obviously we can't do everything, but communication is key, and it actually helps to know the local providers so they can follow for pain, for spasticity, for any kind of other issues. So it's about communication. That's it. Thank you.
Thank you.
Thank you guys for putting this on today, and thanks to the Academy also for starting the Learning Collaborative in an area that's really critical to our existence on bed-level rehabilitation. I'm Bill Adair. My background's in working within a private practice group that's within an integrated health delivery network, Advocate Healthcare in Chicago. And the question I've got for you are twofold, really. In the areas that you're working with an integrated delivery network, where you are part of the system of care, the continuum working with them, how is that different than where you're not in a setting where that's required? And what do you think is going to be the impact of the prospective payment system in SNFs, which is going to constrain them like we have been constrained in terms of episodic care payment?
I would say briefly on the inpatient side, with the PPS that we basically lead the interdisciplinary team, make the decision-making regarding length of stay, I think that would become highly relevant in the SNF setting.
I'll keep it brief, but Bill, I think the key for us is having a seat at the table when these things are being negotiated. I found this to be very interesting. So we are working with Northwestern in Chicago. They're just forming their post-acute networks and their bundles. Northwestern is consulting Sharon Ruddick, who ran Advocates bundle for me. Yeah. So Sharon met Matt and I in our IRC's offices, and she sat there and she looked at us and she goes, "You guys do that? You coordinate all this for free? We would have loved to use you guys when we came up with Advocate system." So this is another instance where they got to the measures they wanted without a physiatrist at the table. It's much harder to insert a cost after the fact. So I think if we're having these conversations and we have a seat at the table when these plans are being negotiated, like we did with Northwestern, they're putting us in all their facilities. They've got about 90 plus facilities. They want us in every single facility, and they're pretty open about it. They're like, 90 is a lot of facilities. If you're not a physiatrist that can cover it, we'll look for other physiatrists in a physiatry-led model. But that's the fear, is that prospective payment systems and whatever you want to talk about, certain risk measures. If we're not at the table when these plans are being negotiated and put together, we're at a risk of being left out.
Yeah, and that's a great point that we need to bring back this afternoon. So I want to get our last two questions in, if you guys don't mind.
There's one piece about the PPS coming for SNFs, if you could address that. If not, that's okay.
Okay, thank you.
Hi, thank you for the interesting talks. What is the role of the technology can play, if any, in taking physiatrists to the next level?
Do you mean technology in general? Any specific aspects of it?
Yeah, technology in rehabilitation. So in terms of, for example, we spoke about providing outcomes and providing clear outcomes or bridging the gap between the world of physiatrist and physiotherapy. So is there any role that technology can play? Is there any help that technology can provide?
If I may summarize it in one word, I think is critical. The EMR is going to be can be a very powerful tool in helping us collect those patient-reported outcomes and all those measures in a way that is meaningful and being able to abstract that data and use it to prove the value of what we do. So that's a whole other hour discussion on its own. Last but not least.
My name's Greg Worswich. I'm at the University of Missouri. I do most of my work in the acute hospital, and where do I send them? And we're developing our integrated network. I have a couple points. One, CMS does not recognize the term subacute rehab. So we know there's 15,000 SNFs in the country, and anybody can be subacute. So A, are we using that term too loosely? Because words have big meaning. Should we say skilled nursing facilities with therapy? So I worry about using that term and credibility. We are looking, I appreciate you talking about quality metrics, because we are looking at how people do based on the location. We've already said we don't have enough rehab docs to cover all these settings. So I worry when we start using that term subacute rehab, we'll have other providers directing the rehab component in these 15,000 places. So I'm just wondering, am I being too picky, or do words have meaning? SNFs have wide variations. Should we then push to have, if we're going to use subacute, maybe more regulatory issues in these settings and make an official term? We have IRFs, we have SNFs, subacute rehab not recognized, but I've heard it used the whole time here. Thanks.
Good comment, Greg. And the issue of definitions has come up recently since we're investigating the issue of a rehabilitation medical director, right, and rehabilitation physicians. So I agree with you, definitions are important, but if we're going to have this conversation about should it be a skilled nursing facility with rehab, should it be a SNF, we need to be maybe thinking about that at the academy level of what do we want it to be, and submit the definition before other entities do. And that's what happened with rehab physician and rehab medical director. So I think you're spot on I think you should worry about that, and that should keep you up at night.
Put this line up for the afternoon.
I know there's some board members here. I would ask our academy to be proactive in this area rather than reactive.
Agree.
Yeah, so please, if you didn't hear, if you didn't have time, et cetera, please join us 2 to 5 this afternoon. We really want to keep this discussion going. Thank you much.